Hello, today we're going to talk about our exemplar of perfusion with the topic of cardiomyopathy. So first let's just look at a little overview of the heart and the cardiac functions. So we know the primary function of the cardiovascular system is to help deliver oxygenated blood to the tissues and return that deoxygenated blood back to the heart. We know it sends blood from the left side into the aorta to the systemic circulation, providing oxygen and nutrients to our tissues and organs. After circulating through the body, through the capillaries, it'll then return into the veins to the right side and then deliver to the lungs to have that oxygenation and remove the carbon dioxide and continue this cycle over and over. We also know that our vascular system helps not only to oxygenate our tissues and our organs and return that volume back to the heart, but it helps the removal and transportation of cellular waste for excretion. It helps to return that lymphatic fluid back into general circulation. So when we look at the functions of the heart and we're looking at cardiomyopathy or a decrease of that cardiac output, a decrease of that cardiac functioning, we always have to think about, is that cardiac function working properly? Is it properly returning the fluid back to the heart? Is it properly transporting that cellular waste to be excreted? When we look at our cardiac conduction system, we know that we have two parts of it. We have our electrical impulse that is then going to fire into that muscle and cause that contraction that then is going to cause that ejection of blood from the ventricles into the body. And this is a cycle that happens in tandem to keep our blood flowing. Right? And so when we look at when that body is ejecting, that is our cardiac output. So our cardiac output is the amount of blood that is being ejected from the left side of the heart per minute. Now, the things that make up our cardiac output is our heart rate times our stroke volume. Our heart rate is something that is variable. It depends on the body's metabolic demands. It can be fast or it can be slow. And then the stroke volume is dependent on your preload, afterload, and contractility. So we talk about preload. This is the amount of blood in the ventricles at the end of diastole. So think about a volume. Your preload is your volume. It refers to the amount of that stretch of the ventricle, that muscle at the end of its filling. If the ventricle over time, and like say in cardiomyopathy, is overstretched, then that ventricle is going to have excess fluid and our preload is going to be high. The afterload is the resistance of flow that the ventricles have to overcome to get into either the lungs or into the systemic circulation. So the right ventricle, the afterload is in the pulmonary artery or the pulmonary valve to get into the lungs. In the left ventricle, the resistance would be going through your aortic valve or into the aorta to get to systemically to the rest of the body. So your afterload again is the resistance that that flow must overcome to open that aortic or pulmonic valve to get the content out. You might see a higher afterload with patients that have hypertension, which would be a systemic vascular resistance, or possibly patients with COPD that have a high pulmonary vascular resistance. And then your contractility is the force of the mechanical contraction. So the contractile force can be increased with your sympathetic stimulation or with medication. So it is our sympathetic nervous system that can positively affect the contractility, or we can use medications to help change that. When we talk about cardiomyopathy, we need to kind of look at its name first. Cardiomyopathy, cardio heart, myopathy, a disease of the muscle. So cardiomyopathy is damage or disease to the heart muscle. So we know that this is going to cause structural changes to the heart. It can cause the heart muscle to become weak, to become enlarged, or to possibly become thicker or more rigid to where it's not compliant. This will then cause a decreased function in your heart muscle, which will then cause a decrease of ejection fraction. So your ejection fraction is the percentage of blood that is ejected from that ventricle with each contraction. A normal ejection fraction is approximately 55 to 65%, but in cardiomyopathy, we typically see it lower. Anything less than 45% means weakness. Anything less than 30% means a severe decrease in that function of the heart. When we see patients with 30% or less ejection fraction or EF, they are at a high risk of ventricular dysrhythmias that can be life-threatening. Cardiomyopathy can be classified into two different ways. So we have primary or secondary cardiomyopathy. Primary is caused primarily by a disease solely or predominantly confined to that heart muscle. So meaning that it could be a gene mutation or a possible genetic disorder, or it could be something as an infection, such as myocarditis that caused damage to the heart. A secondary cardiomyopathy results from some type of underlying condition. So damage from the heart from a possible larger systemic or multi-organ disease process that has affected the heart. When we talk about intrinsic and extrinsic, so intrinsic is referred to a disease that originated from inside that heart muscle. Again, possibly something that is genetic or viral that caused a direct injury to the heart muscle. Extrinsic are external factors that affect the heart, and this can be things such as diet, exercise, and smoking that has affected the heart and the way it pumps. Now, there is many risk factors for cardiomyopathy. This is a small percentage of them, but we see diabetes, hypertension, high cholesterol, high-fat diets, obesity, a family history, sedentary lifestyle, and smoking is some of the main ones that can cause cardiomyopathy. And just remember that this may not be from just one cause, but it might be the result of an accumulation of multiple injuries and insults to the heart from multiple disease processes. We are going to look at three different types of cardiomyopathy. And when we're looking at the cardiomyopathy, again, we're talking about that ventricle, that muscle surrounding your ventricles, and the way it looks and the way it's functioning. So in the pictures you see here, the first one shows a normal heart with the right and left ventricle and the muscles and the septum that surrounds those ventricles. The first type of cardiomyopathy is dilated cardiomyopathy. And we see a ventricle enlargement, and we see where that ventricle muscle becomes stretched thin. The dilated chamber results in poor systolic functioning, impaired contractility, and thus impaired cardiac output. This results in heart failure with the reduced ejection fraction. We see this happen with patients. Sometimes it's unknown, but we see it with toxin use, alcohol, cocaine, viral infections, and it can be even seen with genetic disorders. Most of the signs and symptoms will develop gradually, such as left and right-sided heart failure, symptoms that we will talk about. The next type of cardiomyopathy that we see here is hypertrophic cardiomyopathy. And as you see in the picture, this is where the ventricle muscle thickens at the base and throughout the septum. The heart muscle becomes stiff, and then this will obstruct the blood flow into the ventricle, and thus affect it going into the aorta. The ejection fraction can be normal with this. Typically, we see signs and symptoms when we have an increase for oxygen demand. Hypertrophic cardiomyopathy is the typical cause of sudden cardiac death in young adults. And again, this is the result of life-threatening ventricular dysrhythmias due to that increased oxygen demand poor cardiac output, and reduced ejection fraction. Most of the time with hypertrophic cardiomyopathy is a result of autosomal dominant gene mutations. So we're going to always look at family history when we see this. And then restrictive cardiomyopathy, when we're looking at the picture, we don't see much of a change in the size from the normal heart. But what happens is the ventricle muscles become stiff, fibrotic, and less flexible. So with this, they're not able to contract and push that blood out, and this is where we have the impaired cardiac output. Most causes are from myocardial fibrosis. Again, those ventricles will stiffen and scar, and it's usually typically as a result of other diseases such as amyloidosis or sarcoidosis. Most manifestations are few, possibly asymptomatic. When we look at the signs and symptoms that our patients are going to have, we think about heart failure. So typically most patients are going to have a mixture of both right and left-sided heart failure symptoms, but we can break them down into what each of them is causing. If you think about the right ventricle being overstretched and overfull, we have that excess fluid on our right ventricle, and that's going to then back up systemically. So this is where we see patients with peripheral pitting edema, that excess weight gain from that excess fluid from edema. That can be also in the form of ascites or abdominal distension from that fluid building up there. And then we see patients with jugular vein distension and dysrhythmias. On left-sided heart failure, this is where we have that overflow of blood in the left ventricle, and so it could be possibly backing up towards the pulmonary side. So you're going to have more trouble with shortness of breath, orthopnea, proximal nocturnal dyspnea, fatigue, increased coughing, wheezing, crackles, that wetness that you're going to hear in the lungs. And again, your patient's going to possibly have more difficulty with hypertension and seeing signs like that. The goal of care is to always try to manage these signs and symptoms, and we want to delay the disease progression and help reduce any risks of complications that the patients might have. So we want to assess our patient. We want to do just a general assessment of all of patients every time. We want to know what their color is. Are they breathing normal? Is their skin warm and dry? Are they diaphoretic? Is there any restlessness, agitation, or confusion? And why would we look at that? Remember what our first sign of decreased oxygenation is? Neurological signs, right? We're going to notice what their weight is. We're going to monitor that weight. Is there any weight gain or weight loss? Do they appear short of breath? How is their mobility? And again, we're going to monitor vital signs. We want to know what their heart rate is, what their rhythm is, blood pressures, and oxygen saturations. And then when we look into cardiomyopathy or heart failure, we're going to get a little more in depth with our assessments. We're going to look for cyanosis. Is it central or peripheral? Is there any blue coloring to the skin, the nail beds, the lips? What is their capillary refill? It should be less than 3 seconds. Is there any edema? Is it pitting or non-pitting? Is it in the lower extremities, upper extremities? Do we notice any edema across the abdomen? Are they more swollen, possibly from ascites? Do they have jugular vein distension, which would be a big indication of right ventricular failure? Is there any clubbing to the fingers or toes? This is typically a sign of long-term systemic hypoxia. Some of the studies that we're going to look at for cardiomyopathy is chest x-ray that can show an enlarged heart as well as fluid in the lungs. An echocardiogram can help estimate the size and motion of the individual chambers, the heart valves, and how much blood is actually being ejected from the heart. So this is where we can see information on our ejection fraction. EKGs are performed to look at any electrical disturbances of the heart. It's going to give us information about their heart rate, their rhythm, because remember, cardiomyopathy can lead to very dangerous ventricular dysrhythmias such as VTAC or even atrial dysrhythmias such as atrial fibrillation. We might do heart catheterizations to look at the vessels surrounding the heart and to look at the actual pumping of the heart. We're going to review overall cardiac output with right heart catheterizations. A cardiac MRI or nuclear studies can help create a more in-depth image of the size and shape of the heart. We can be doing laboratory studies that directly affect the heart, such as the BNP, and we might also be doing other chemistry tests to look at liver functions, thyroid, kidney functions, and CBCs to evaluate for anemia, which would be decreased blood flow. And then we might look at genetic testing and myocardial biopsies if we're looking at possibly hereditary disease. Some of the labs that are more specific for cardiac damage will look at the creatinine kinase, which is a general marker of cell injury. Your CKMB is more specific to your cardiac tissue. A troponin is specific to cardiac injury. It is usually elevated within the first 4 hours and can remain elevated for up to 10 days. Myoglobin is released in response to any type of muscle damage, so it's not necessarily cardiac specific. And then the brain natriuretic peptide, or a BNP, this is very specific to cardiomyopathy or heart failure, as this type of enzyme is released in response to the ventricular tissue stretching. So this is where we see that indicator for heart failure. This is just a little chest x-ray that shows the size of a normal heart versus a enlarged cardiomyopathy. And then our medical management. So there are many medications that we are going to use to help manage cardiomyopathy. We know that our ACE inhibitors are our prils, our enalapril, lisinopril. That's going to be our gold standard, as this is going to help improve preload, improve afterload. Same thing with your angiotensin receptors. This is also a vasodilator to help improve that preload and afterload. Our calcium channel blockers are going to help relax that smooth muscle and cause dilation. Our beta blockers, they are going to help decrease our heart rate. Digoxin can help be used to slow the heart rate and also improve muscle contraction. Diuretics will help decrease that edema and decrease the preload. Anticoagulants is going to decrease the risk of thrombus. Aldosterone blockers will help correct possibly some imbalances. And then we might be using antidysrhythmics to help prevent any dysrhythmias that could be caused from our decreased cardiac output or our decreased EF. There is a great chart in your book that goes in depth with these medications, and I really highly recommend you're looking at these medications. You're not only knowing what they're doing, but know the names of these medications. Know the side effects. Know any contraindications to these medications. It's real important that we're knowing not only how they're working, but knowing any kind of side effects or contraindications that could be used. And then also any lab values that could be associated with these charts or these medications, such as your anticoagulants. What is your heparin monitored by? What is your Coumadin monitored by? With your diuretics, what's the big electrolyte we're looking at for that? So real important that we are looking at those. When we go into more of a medical management or a surgical management of cardiomyopathy, we talk about pacemakers or implanted cardiac defibrillators. So a pacemaker, a biventricular pacemaker, can help send signals to both the lower chambers of your ventricles, making them contract and strengthening that pumping function, which will improve your blood flow. An implanted cardiac defibrillator is recommended for patients with a reduced ejection fraction. Again, that's less than 30% because they are at high risk for lethal dysrhythmias. And when we have that implanted defibrillator, we don't typically go straight for that. Initially, they're going to have a life vest, which is a wearable external defibrillator. And these patients might be on that life vest for several months while they're using medications to try to help improve the cardiac functioning. But if medications aren't helping, this is where we would go to an implanted defibrillator. Your patients might end up needing cardiac transplant. This is a definitive treatment typically seen with the dilated cardiomyopathy. It is not an option for restrictive cardiomyopathy, as that is due to an external process that's causing that. Your LVAD is your left ventricular assisted device, and we'll talk a little bit more about that, or your ECMO mechanical pump. And then you could possibly have surgical ventricular remodeling to help reduce that left ventricular size and improve that septal functioning to help increase that blood flow. So this is just a little picture of a implanted cardiovascular defibrillator. So when the patient was to go into a lethal dysrhythmia such as VTAC, it would send an impulse that would actually shock the patient. And then this next picture is just a picture of the left ventricular assisted device. So it is actually a pump that takes blood from the left ventricle and takes it and pumps it to the aorta. And so it's connected like that to help just get the blood to the systematic body, because the left ventricle just does not have that pumping function anymore. So we look at the nursing management of cardiomyopathy. Again, just as a recap, we're going to do that assessment and analysis. We're going to anticipate any signs of heart failure. We want to make sure we are recognizing any complications. Do they have any heart failure? Is the heart able to have enough cardiac output to meet the body's metabolic demands? Is there any dysrhythmias, atrial fibrillation, ventricular tachycardia, anything like that that we need to be watching for? And again, if we talk about atrial fibrillation, we always want to make sure we're talking about reducing the risk of blood clots. So this is where patients can be on anticoagulants. So we want to make sure that we are monitoring for any type of thrombosis or clot formation that could lead to any further complications and issues. Looking at our nursing interventions, a recap again, we're going to do assessments. We're going to look at their full vital signs, heart rate, heart rhythm, vital signs with their blood pressure and your oxygen saturation. We're going to look at their neurological status. The first sign of decreased oxygenation is going to come with confusion, restlessness, and agitation. We're going to monitor that EKG and their heart rhythm. We want to monitor their lung sounds and provide oxygen if they are having a decrease in oxygenation. Monitor for any chest pain. Look at their activity tolerance. Physical activity will increase that oxygen demand. So we need to make sure that they are aware of taking time to rest, taking time to do their activities. We want to make sure that they are in a good position to help assist with preload and ventricle filling. So we want them in a semi to high Fowler's position. That's going to decrease their dyspnea. Look at their urine output. Are they holding on to fluid? What does the edema look like? We're monitoring their laboratory test, again, that BNP, looking at other electrolytes and systemic body testing. And then we want to make sure we're administering any medications as ordered to help with signs and symptoms and prevent complications. Monitor for those signs and symptoms of heart failure. Again, we want to recognize that the patient, as soon as they have any symptoms of heart failure, the sooner we can get treatment, the sooner we can possibly prevent that hospital admission. So increased shortness of breath or weight gain, we want to know that they're having excess volume. If they have excess fatigue, they're having decreased cardiac output. Any type of abdominal swelling or fluid could be due to that increased fluid gain from ascites. We want to make sure that they know their medications, that they know the purpose of the medication, their dosages, and any potential side effects that they're on with that. We want to make sure they are aware of dietary fluid restrictions. So a lot of patients with cardiomyopathy not only will be on sodium restriction, but they might be on a fluid restriction to help decrease that volume overload. And then we want to make sure that with their dietary restrictions, they understand, especially if they're on any diuretics, the process that it has on their potassium, depending on if they're on a potassium sparing or potassium wasting diuretic. Because what does potassium do? It can cause cardiac arrhythmias, right? We want to look at their exercise regime. Of course, we don't want them completely sedentary, but we want them to have moderate exercise and understand that this will help improve symptoms and their exercise capacity, but they need to make sure that they are taking it easy, that they are exercising in moderated or monitored settings. We don't want them smoking, and we want them making sure that they're able to manage their daily living activities. These are some of the nursing diagnoses associated with cardiomyopathy. Again, we're going to look at that decreased cardiac output and what is that doing systemically to our body. Could be causing fatigue. Is that causing volume fluid excess, activity intolerance, knowledge deficit, and even grieving? This is going to be a big change for the patient, their way of living and how they have to do. So it could be a process to help provide additional support and resources for these patients and their families. Now, if we get to the point where we have patients that go into extreme heart failure, we have a risk of going into cardiogenic shock. So we always want to make sure that we're looking for any signs of symptoms that are related to that decreased cardiac output. So again, we're monitoring our vital signs. We're looking at our breath sounds, oxygen saturation, our neurological status, skin color and temperature, and lab work. Patients that are in cardiogenic shock, of course, are going to see a decreased level of consciousness, decreased oxygenation. Typically, blood pressure readings are going to be lower. Skin temperature is going to be